the endocrinology section. You think like, what physical findings are there? You can like show me like physical findings of palpating a gland? You know, like what physical findings can there be with endocrinology? And well, here's the first one. Who is this very ugly, ugly, ugly man? Big head, big hat, big ring, big nose, big toes, big shoes, big, not that, because that's sort of a metaphor about bone. Penises don't get big in, what is this? Big head, big sweating. He sweats. He's got colon cancer. Why? Because the polyps in the colon get bigger. And this man here, he has, oh, acromegaly. Look at that. Acromegaly. And acromegaly is abnormal growth hormone secretion. This is an autonomously functioning adenoma in the pituitary. This is making growth hormone because it's an adenoma. Why does that happen? Adenoma? Because I don't know. It's just happening. See, normally sugar should shut off growth hormone. But these people, the sugar does not shut off growth hormone. That's why sugar goes up, because growth hormone is anti-insulin. Growth hormone is an anti-insulin. Growth hormone is an anti-insulin, so therefore glucose and lipids go up. Normally glucose and lipids should shut off growth hormone, yet here's the oversecretion. How can the glucose be up, but the growth hormone is up? How can the glucose be up, but the growth hormone is up? Because glucose should shut off growth hormone. How can the growth hormone be up? Because it's a disease. Then what is so insulin-like about insulin-like growth factor? And the answer is, it's an anti-insulin on glucose and lipids, but it's insulin-like in its effect on proteins. Proteins. Large hands, large head, large shoes, large nose, large toes. The best initial test is an IGF level. The best initial test is an IGF level because insulin-like growth factor goes up. Why IGF? Because growth hormone. Now here's where we get to physiology. This is endocrine physiology. Welcome to Step 1, Complex 1. Step 1 and Complex 1. This is the physiology of why is IGF first? Because IGF is the only peptide hormone with a protein carrier. It's the only peptide hormone with a protein carrier, and therefore the half-life is long. Growth factor. I don't understand. People who are acromegalic, acromegaly causes high glucose, high lipids. What's insulin like about that? I thought insulin lowered glucose and lipids. Because the IGF is insulin-like in its effect on proteins, but not in its effect on sugars and lipids. Growth hormone's effect on sugars and lipids is to raise the sugars and lipids. So it's an anti-insulin. But IGF is like insulin on proteins. Growth hormone has very short half-life, and that's why it's not the best initial test. Because it's a half-life that's short and it's in the middle of the night. The sun was shining very brightly, shining with all of its might, which was very odd, you see, since it was the middle of the night. So we don't want to be doing growth hormone levels in the middle of the night because it's a short half-life and it's very hard to get them. IGF levels is first. Oh, there's our friend, the pituitary, up in the sphenoid. I'm going to put myself in your sphenoid. And you pluck it out. Tasty pituitary, isn't it? So the most accurate test is to give glucose and to see that there's no suppression. A normal should suppress. Abnormal won't suppress. Normal will suppress. Abnormals won't suppress. And abnormals won't suppress because it's a disease. You see, if it's suppressed, it wouldn't be a disease. If it's suppressed, it wouldn't be a disease. Because the whole point is glucose should suppress growth hormone and IGF. And you give glucose and it doesn't suppress. That's why it's a disease. So the abnormality is confirmed with an MRI, and then you go up the nose and pull it out. Acromegaly. Big hat, big ring, big nose, big toes, big sweat glands. So this is the beauty of the tyrosine kinase. Tyrosine kinase receptor is where the external ligand is a $5 word for transmitter, and it flips through, okay? And so what ends up happening is that the pituitary is making growth hormone, which goes down and makes everything else grow. But it is the effect on the muscles, the IGF, that's insulin-like. That's the protein growing part. And this, the tyrosine kinase. So the tyrosine kinase is the insulin-like part, because this part is what makes the proteins grow. Like this guy, yeah. Andre the Giant. Ooh, I'm getting smaller. Ooh, I feel smaller. Now, Andre the Giant would not let himself have the transsphenoidal surgery. Andre the Giant would not have the transsphenoidal surgery, so consequently, Andre here, what ended up happening to him is that Andre ended up dying of acromegaly from congestive heart failure in his late 40s because he did not allow the transsphenoidal surgery. And now here's the pituitary gland, and this is a picture of having this thing cut out. This is transsphenoidal surgery. This is the forceps on your right are cracking through the base of the skull, cracking through, then suction on the other part, and then it's going to literally suck out your pituitary gland, and that is sucking out a pituitary through transsphenoidal surgery. Now, endocrinology. Endocrinology, you have Trostick sign. Okay, endocrinology, Trostick sign, hyperexcitability of the facial nerve. Hyperexcitability of the facial nerve. And it's because low calcium makes neural tissue hyperexcitable. Low calcium makes neural tissue hyperexcitable, so you have Trousseau's, Trostick's, okay, and Trostick's is hyperexcitability of the facial nerve. It makes it twitch, upper and lower. Now, when you see Trostick's in the question, this means hypocalcemia, low calcium. Low calcium makes all neural tissue hyperexcitable. It makes the 7th cranial nerve contract even when you don't think it should be contracted. So it's a sign of hyperexcitability of neural tissue. And it's caused by depolarization of half of the face that goes into half of the face that goes into half of the face that goes into spasm. And this is from low calcium. Low calcium actually makes sodium channels open earlier. Low calcium actually makes sodium channels open earlier, so it causes hyperexcitability. That's right. Low calcium makes neural channels open earlier. And so that is why when you see Trostick's, or Trousseau's, this means low calcium lowers the threshold. Low calcium lowers the threshold at which sodium channels open, and therefore you get excessive depolarization of that facial nerve. Anatomy, the anatomy of the facial nerve. The anatomy of the facial nerve goes to the upper, the middle, and the lower part of the face. The upper, the middle, and the lower part of the face. The upper, the middle, and the lower part of the face. What do the vagina and the 7th cranial nerve have in common? They both supply taste to the anterior 2/3 of the tongue. So that is why the 7th cranial nerve also affects the lacrimal glands, taste receptors in the anterior 2/3, and salivary glands. Now that's why it is that facial palsy is associated with a loss of taste on the anterior 2/3 of the tongue. The facial palsy. Facial palsy is associated with a loss of taste in the anterior 2/3 of the tongue. It's associated with dryness of the eyes. And here is depolarization. This threshold at which you depolarize becomes lower. You depolarize earlier when you have low calcium. That's why high calcium raises threshold, low calcium lowers threshold. High calcium inhibits depolarization, low calcium makes depolarization easier. High calcium inhibits depolarization, raises threshold, see threshold for depolarization? And low calcium lowers the threshold for depolarization, makes it easier to depolarize. See, these are sub-threshold stimuli, but if you had low calcium, they would depolarize. So, this is depolarization of the facial nerve or any nerve, and it makes it easier to depolarize when the calcium is low, hyperexcitability, and seizures. Low calcium, easier depolarization. High calcium, harder depolarization. If you can get this principle today at your level of training, you'll be amazingly ahead of the game. Low calcium lowers the threshold, makes it easier for sodium channels to open, and you depolarize earlier. Prostax, Trousseau's, hyperexcitability, and seizure. High calcium glues shut sodium channels. It makes it harder to depolarize. Yeah. German beer, Frau? No, not German beer, Frau. It is Cushing's disease? Yes. The most accurate test, 24-hour urine cortisol, 1 milligram dexamethasone, 24-hour urine cortisol, 1 milligram overnight dexamethasone. The therapy, whatever you find in Cushing's, we remove it. If it's in the adrenal gland, we remove it laparoscopically. If it's in the pituitary, we remove it through the sphenoids. If it's in the chest, we remove it surgically. Whatever you find that causes Cushing's syndrome, hypercortisolism, we remove it. Remove the pituitary, remove the adrenals, remove the ectopic. Whatever you find that's overproducing, remove it. Because the drugs that inhibit it are crap. Why do you get, what is that? Huh? Ishhada, achi? And the answer is, that is stria. Now, stria are a sign of sugars being made out of your skin. Did you know that 90% of the proteins in your skin are glucogenic? Out of the 20 or 21 amino acids in human biology, 18 of them are glucogenic. 18 out of 20 human amino acids can turn into sugar through gluconeogenesis. Wow, really? And that's why it is that these stria happen. Because cortisol takes the skin and turns it into sugar. Takes the bone, turns it into sugar, because that's the biochemistry of this. The biochemistry of this is not that they're going to ask you about moon face. No. The stria are from thinning skin. Why does the skin thin? Because skin is collagen. And collagen, like alanine and lysine, lysine and alanine, can be turned, glycine, lysine, and alanine can be turned into sugar. Period. Thank you very much. Hypercortisolism of Cushing's, the face and the neck develop abnormal fat distribution. It's not clear, by the way, why it is that fat is melted out here peripherally, but forms here. It's not clear. It's not clear why. Okay, it's not clear why. But it happens. Stria develop because cortisol inhibits collagen fibers because collagen is protein, and the protein gets destroyed. The protein gets destroyed. So let's see, what do we got here? The hypothalamus comes down to the pituitary. The pituitary goes down to the adrenals. Welcome to one of our favorite pictures of who you're staring at. The hypothalamic pituitary target organ arc. Corticotropin releasing hormone makes ACTH. ACTH makes cortisol. Corticotropin releasing hormone makes ACTH. ACTH makes cortisol. Hypothalamic pituitary axis and feedback inhibition. Now, what's the only feedback inhibition on the pituitary? Is cortisol. That's the question. There's a lot of things that can go back there, but the only one that happens in the adrenals that's feedback is not aldosterone, not DHEA, not androstenedione. It is cortisol. The only thing that's feedback inhibition of the pituitary, ACTH makes cortisol. Cortisol should shut it off. Now, the stria and the bone abnormalities happen because proteins. Here we're going to biochem, man, and the proteins break down, they're glucogenic. What does that mean? It means that 90% plus of collagen and bone matrix can be turned into sugar for gluconeogenesis. And those glucogenic amino acids turn into pyruvate and oxaloacetate. That's how they get into sugar. Next is phosphoenolpyruvate. Pyruvate, oxaloacetate, and these get converted into glucose. This is the opposite direction of glycolysis. Let's say it again. What happens is that you have amino acids turn into fumarate, malate has to go out of the mitochondria, and then what do we get? There it is, oxaloacetate. Phosphoenolpyruvate can get converted back up to sugar. This is the process of gluconeogenesis. It goes in the opposite direction. It goes in the opposite direction as glycolysis. Glycolysis would go down this way. Gluconeogenesis goes up. So, fumarate is where some amino acids come in. Oxaloacetate is where other amino acids get in. And what's the major point about this? Those stria as a physical finding. The step one question is, how did that happen? Why? Because cortisol wants to turn the skin and bone proteins into oxaloacetate and fumarate so it can be a substrate for phosphoenolpyruvate. Because this is gluconeogenesis. Gluconeogenesis is not easy. What's the major effect of cortisol on raising sugars? It's actually not gluconeogenesis. It's actually inhibiting the uptake of the glucose. What are you saving the sugar for? Brain. What's the mechanism of stria? I asked an attending this day, an attending endocrinologist, what's the mechanism of stria? And he goes, well, you know, the sugar, you know, the steroids thin the skin. I go, yeah, that's what stria mean, thin skin. But why do you thin the skin? Well, because it does, yeah. No. Step one, complex one says, I want to know the mechanism. And you have to know that those amino acids are glucogenic, and those glucogenic amino acids come out of the collagen of the skin because the majority of its skin is amino acids are glucogenic, like glycine, proline, alanine, lysine, and they get converted into glucose. Because over here with amino acids, glucogenic amino acids get turned into pyruvate and oxaloacetate. And the pyruvate and the oxaloacetate end up as sugar. Your moral story is to know, how do you get these things to go into pyruvate, and pyruvate comes out as sugar? The answer is gluconeogenesis. You have glucogenic amino acids forming fumarate, oxaloacetate, alpha-ketoglutarate, and those are the biochemical pathways for forming sugars. Amino acids that go in at pyruvate, these go in at pyruvate. Okay? And when they go in as pyruvate, they go in as pyruvate. When they go in as pyruvate, cycle. This is like the terminals at John F. Kennedy Airport. First stop American Airlines, second stop Terminal 4, Delta, JetBlue, kiss your ass goodbye airline, and oxaloacetate. So this circle is saying, I understand that these are the different ways that glucogenic amino acids enter the cycle and end up in sugar. Cushing's syndrome, Cushing's disease. You can take this beautiful fresh-faced boy and turn him into that dude over there. Now, it can do that because it's causing an abnormal pituitary hypothalamic arc, because it's coming out of the hypothalamus into the pituitary. ACTH goes down to the adrenals. Now, first of all, you do a 1 milligram overnight dexamethasone suppression test or 24-hour urine cortisol, because pituitary tumors have a high ACTH too. So first you want to say, does this person really have hypercortisolism? Let's see if they really have hypercortisolism. And that's why these first two tests are to see if you really have hypercortisolism. But it doesn't tell you where it's from. The first test to determine the etiology is in fact the high ACTH level. The high ACTH level will actually turn this into knowing it's a pituitary problem. The high ACTH level tells you know it's a pituitary level. Adrenal adenomas have feedback inhibition with the cortisol coming out of the adrenal, and adrenal adenomas make cortisol. Cortisol suppresses ACTH. Cortisol suppresses ACTH. Cortisol suppresses ACTH. Now, the sella turcica is how you go through to pull that gland out. This is saying, okay, you know it's in the pituitary. How do you get rid of it? Put a spoon up there and suck it out of your transsphenoidal sinuses and pull it out. And that's the end of the first part of endocrinology. I wish you well. We'll see you in the next section. This is hard. You should expect to have to go it 3 to 5 times. See you soon. Hey, here we have some more endocrinology, and there's nothing to get up our game like drippy white nipples. Drippy white nipples make us interested in endocrinology. Actually, they make us interested in wanting to go into orthopedic surgery. Now, how did you get so drippy and white? Oh, yeah, it's disgusting. Oh, these breasts outside are frightening, and this milk is surely whitening. When there's really no place to go, let it flow, let it flow, let it flow. It's galactorrhea, and rhea is from the word rheology, for to flow. And this is a person, see, normally the pituitary should have a shut-off level of prolactin. See, prolactin is in favor of lactation. That's why it says prolactin. Are you for lactation? Yes, I'm for lactation. So you're pro-lactation. Yes, I'm pro-lactation, 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 prolactin. And the hypothalamus normally shuts that off with dopamine. Now, when you have a pituitary adenoma, the pituitary adenoma makes an excess amount of prolactin, and it starts to make that milk outside so whitening. And these breasts are surely frightening when there's really no place to go. Let it flow, let it flow, let it flow. And it's an abnormal flow of milk from the breast, galactorrhea, that has caused well, normal pregnancy does it, sure. But the thing is that prolactin levels are elevated from pituitary adenomas, which you make first a diagnosis by you exclude pregnancy. So first let's exclude pregnancy. Exclude pregnancy, then you scan the brain. Exclude things like nipple stimulation and nipple piercings and zoster and certain medications like psychiatric medications. Why do psychiatric medications increase prolactin? Because psychiatric medications inhibit dopamine. Dopamine stops prolactin. Dopamine stops prolactin. So when you use psychiatric medications, they inhibit dopamine and the prolactin flows. Now, one of the few cross reactions in any endocrine system is thyrotropin-releasing hormone. Hormones have tremendous organ specificity. You will not find ACTH stimulating the heart. You will not find thyrotropin-releasing hormone or ACTH or growth hormone-releasing hormone stimulating the colon. But one of the only places of cross-reaction is when you have hypothyroidism at extreme levels. Thyrotropin-releasing hormone increases prolactin. This is only at extreme levels, and it's rare. Now, galactorrhea is evaluated by first pregnancy test. Until you exclude pregnancy, or unless the patient is a man, there's no point in having any discussion about what to do about high prolactin levels, because high prolactin levels are just a normal part of pregnancy and the prolactin levels. Now, then, after you look into the pregnancy and the high prolactin levels, then you scan the brain to see, are you having a pituitary lesion. Anatomy, ooh, look at that. Look at that big juicy. It's amazingly tiny, really. It's 7 grams. It's a quarter of 1 ounce, 7 grams. It's a teeny tiny organ. It's a teeny tiny organ, and your point is here is that in prolactin, the normal physiology, thyrotropin-releasing hormone could elevate it. So wonderful to study one, isn't it? So is this one. This is where the things are made inside the paraventricular and supraoptic nuclei, but they get stored in the anterior pituitary. They get stored in the anterior pituitary. Stored in the anterior pituitary. Even though they may be made up there, they stimulate something else to store them in the anterior pituitary. Now, the anterior pituitary, or the hypophysis, remember, hypophysis and pituitary are the same thing, has 6 hormones: ACTH, LH and FSH, prolactin when it wants to, thyroid stimulating hormone, growth hormone, 6 hormones. The posterior pituitary only has 2. It only has antidiuretic hormone and oxytocin. Antidiuretic hormone and oxytocin. And see the relative sizes of things. Now, the point about this question is that there are certain people who have pituitary lesions that are so large they can cause mass effect. Pituitary lesions that are so large they'll even cause mass effect, and they're certainly functional. This is a pituitary lesion. This is a pituitary lesion, and change. This is a pituitary lesion. These are both pituitary lesions. Neither of them has cancer, carcinoma. Okay, they're both adenomas. Now you can have a macroadenoma before cabergoline and shrinkage down, doesn't look too shrunk, with cabergoline. And this is medical therapy for a prolactinoma. The medical therapy is shrink that prolactin secreting tumor, shrink it up, and by giving you cabergoline. Now, not bromocriptine, because cabergoline has less adverse effects. Next one, we have a person with a, what is it? What is it? It is a goiter. Wow, isn't this guy looks terrible? He looks so unhappy. And yet here he is, and he was too poor to afford, the trips to go to places to get his iodine, and here's a goiter, and you got to stay domestically. So what do you do with that? It's like, this is the United States, man. That goiter. Now, the only thing about goiters is you can't tell whether it's low thyroid, high thyroid, or normal thyroid just by having a goiter. You can't tell which one it is. You could have a goiter with hyperfunctioning. You can have a goiter with low functioning. It can be any level. Hyperthyroidism, hypothyroidism, normal levels. And the etiology of a goiter is determined based on TSH and T4, meaning that if you have a high TSH, it means, one, you have a TSH-producing tumor. That's one thing, if you have a high TSH. Now, solitary thyroid normals, these ones need to be biopsied because you have no idea whether those nodules have cancer in them or an adenoma. Now, a goiter by itself doesn't need to be biopsied, but solitary nodules that are neoplastic have to be biopsied and have to be able to say, hey, does this person have symptoms of hyperthyroidism? Pause, summarize. You see, the whole point is the thyroid gland. Here's a normal gland, here's a nodular gland that's a lot larger than normal. It's not goiter really, because goiter doesn't need its gland removed. There's a nodular goiter that allows us to know that we're not treating cancer. This is a nodular goiter. Look at all the colloid. Ooh, I feel like swimming in it. This is normal proteins inside the thyroid. That's the glandular nature of things, the secretory nature of things. See, that pink is normal thyroid hormone, that pink is normal thyroid hormone, that pink is normal thyroid hormone. These levels are normal thyroid hormone. Big, huge lakes and rivers and oceans looking at the thyroid hormone. Who's this big-eyed lady? So what is this? It's eyes. What's the most accurate test? Ooh, high T4 and a low TSH. High T4 and a low TSH. The therapy for this bug-eyed lady, you can radiate the eyes, steroids, radiation, steroids, radiation, steroids. And the reason why that is an ophthalmologic emergency is that if you don't do the right... So the reason that we say go pick stuff up here is that this person, you see, this is hyperthyroidism, not just because there's mucopolysaccharides behind the eyes pushing them forward, but because, let's get that one again, mucopolysaccharides behind the eyes pushing them forward. It's also because the third cranial nerve stimulation stimulates the levator palpebrae superioris. Third cranial nerve stimulation gives proptosis at exophthalmos because, another big I did, because you have the hyperthyroidism pushing the eyes forward. Remember, proptosis and exophthalmos are the same thing. Proptosis and exophthalmos are the same thing, and what they squeeze the eyeballs. The ocular finding in Graves' disease is exophthalmos, and the lid lag is because thyroid hormone is stimulating the third cranial nerve, because thyroid hormone, it has sympathetic activity, and the third cranial nerve can lift the eyeballs out of the way. The third cranial nerve can lift the lid out of the way. And so you get lid lag. Exophthalmos, deposition of mucopolysaccharides behind the eye. It's the same term as proptosis. So when you see the word proptosis and exophthalmos, they mean the same thing. Lid lag is a way of saying the third cranial nerve has excess stimulation and you look bug-eyed because there's excess stimulation of the third cranial nerve, because T4 or thyroxine is going to stimulate and potentiate the sympathetic nervous system. Now, thyroid function tests, the T4 and the thyroxine and the TSH are the best tests to use for first to say, do you have hyperthyroidism? The radioactive iodine is not to tell you, do you have hyperthyroidism? Radioactive iodine is to say, where's it from? Radioactive iodine is to say, where is it from? Because the management is different based on the etiology. Now, for thyroid storm, we're going to do propranolol first for everybody. Propylthiouracil and methimazole are done as soon as the thyroid storm is given away, as soon as it's stopped, because these stop production of thyroid hormone. And the gland is ablated later on with radioactive iodine. That's what happens later on. Just kill off part of it. So this should not be new for most people if you really ever studied it. If you really ever studied it, you will say the levator palpebrae superioris is stimulated by sympathetic twigs that are under the control of third cranial nerve, and it lifts up the eyelid. Lid lag. Ah, lid lag. Oh, levator palpebrae superioris pulls it up, pulls it up, pulls it up, pulls it up. And what ends up happening is, how do you pick up that muscle? Is that muscle is stimulated by thyroid hormone. That muscle is stimulated by thyroid hormone, Marty Feldman. And what you see here is different nuclear studies of radioactive hyperthyroid scans saying when you have Graves' disease, you have a greater pickup of the radioactive iodine. And that's why Graves' disease is the only one of the causes of hyperthyroidism in which you have an increased function. Toxic nodular goiter, just leaking. But increased function, Graves' disease, radioactive iodine. Almost done. Gynecomastia is half similar to the things we just said before, because gynecomastia is with pituitary lesions. Gynecomastia is from people who make prolactin, and gynecomastia depends on what the etiology is to solve this problem, because gynecomastia means your man boobs are extra booby. Is associated with high prolactin, because prolactin secreting tumors make glands big. Why does it make the gland big? Because prolactin literally directly stimulates glands. Liver disease and cirrhosis decrease the clearance of prolactin. So liver disease and cirrhosis is the same thing as saying high prolactin. And estrogen levels and these medications also, the effect that they have is on the levels of prolactin and androgens. Now, drugs such as spironolactone is anti-androgenic. That's spironolactone anti-androgenic, and phenothiazines have an effect on dopamine that increases prolactin. So you treat the underlying cause, and then cut it out. Oh, now for something completely different, as they said, Trousseau's-sign. Somebody, I joke around with people like that. The boss comes by, the old boss, I should say, and they go, oh, hey, and I go, oh, it's just my Trousseau's sign. So Trousseau's sign, or carpopedal spasm, says, I understand that low calcium increases depolarization. I understand that low calcium increases depolarization. So what I'm going to do is I'm going to test that. And I want to say low calcium. And what happens in Trousseau's sign is that we occlude the arterial flow and look for flexion of the wrist. And this Trousseau's sign, when the hand depolarizes, everything depolarizes, also carpopedal spasm, because you're depolarizing, is another way of saying to people, you have to go make an exploration of why these signs occur. Low calcium causes neural hyperexcitability. Okay, low calcium, you inflate the blood pressure cuff. Ooh, why does that do it? Because it causes more lactate. Why does that do it? Because it occludes blood flow to the muscle in the arm. And now, low calcium increases neural hyperexcitability. And the neural hyperexcitability is associated with low calcium levels. Let's see about this Trousseau's. Oh, he's squeezing. Almost there. Oh. Trousseau is a gynecologist, they say. It's going to happen again. I can see it's like watching Titanic thinking, oh no, it won't hit the Titanic this time. Oh, you see? Oh, squeeze. Totally reversible. Totally reversible. That's reversible. But death is not reversible. Low calcium increases hyperexcitability of tissues. See you in the next section.